So the main things is to follow the steps right from the delivery room, and obviously the neonatal resuscitation program guidelines is ideally practiced so that everyone is in sync. The initial ventilation pressure is 20 to 25 centimeters water. Set the PEEP at 5, and it's obviously better to use the TP's device like NeoPuff. The flow should be set at 10 liters. Don't adjust the flow unless you're not able to achieve the pressures, because if you adjust the flow, the set pressures will change. And educate the team on the importance of keeping the flow constant once you set the pressures so that there is no confusion. And as I mentioned, a NeoPuff is better than the self-inflating bag, mainly because the PEEP is delivered and the pressure is controlled, while in a self-inflating bag, you have more flexibility with the pressure that you need, but at the same time, you may be overdoing the pressure, and the lack of PEEP is a big disadvantage when it comes to managing premature babies. CPAP in the delivery room can be safely applied, and if the baby has a reasonable respiratory effort and is just having distress or difficulty oxygenation, you start with CPAP, and you can use the NeoPuff with a mask, and you can switch to the nasal prongs at transfer. Try to use a transport ventilator with a nasal CPAP. I mean, having the NeoPuff during transfer means you open the incubator door, which affects the temperature. It's difficult for the person walking along to be crouching with the mask as well, and the seal may not be appropriate as moving. So try to use the nasal prongs. Train your team on setting the transport ventilator and moving with the prongs. It's very important at this stage to remember that appropriate temperature care is important, because if the baby gets cold, the surfactant utilization is affected, the recycling of surfactant is affected, so baby might need more respiratory support. And this doesn't apply just to the premature babies, it applies to the larger babies as well who have respiratory distress. There are recent studies which look at more frequent use of the laryngeal mask airway, both in the labor room scenarios as well as in the NICU, if the baby needs IPPV during the course of management, like in case of apnea. The efficacy of the laryngeal mask airway is better, and there is more consistency than using a mask, because the positioning of the mask may vary from person to person, and if your concentration is changing, it might go off. So if you expect to need a reasonable length of IPPV with a mask, it's better to consider laryngeal mask airway. Hopefully we'll have the smaller sized one so we can use it in babies less than 34 weeks as well. Currently, the size 1 is applicable for more than 34 weeks, even though from personal experience, many colleagues have said around 1500 grams and above, they're able to use it.